SARS struck around 30 countries with a crude mortality rate about 11%. The emergent infectious disease caused by coronavirus is the first global epidemic in the 21st century. Due to the novelty of the disease, unexpected outbreak, unpreparedness, and failed medical response, SARS caused 8,422 confirmed cases with 916 deaths globally. For medical caregivers, personal protective equipment, including powered air purifying respirator, was recommended to wear against SARS. In addition, airway managers and intubators were recommended to use video laryngoscopes to perform tracheal intubation to avoid possible contamination and infection. Unfortunately, the reality was that such personal protective equipment and video laryngoscopes were not adequate or available in most countries and regions during SARS epidemic. In Taiwan, between March 14 and July 30, 2003, a total of 668 probable cases of SARS with a mortality rate of 27% were reported. In hospital, equipped with primitive personal protective equipment, anesthesiologists could only use conventional direct laryngoscopy to conduct tracheal intubation in 70 SARS patients. Many years later, human history just repeated again. Coronavirus disease 2019, a contagious disease caused by severe acute respiratory syndrome coronavirus 2, hit the world in 2019 without warning. Up to December 10, 2021, there are 267,865,289 confirmed cases and 5,285,888 confirmed deaths globally. Due to geographically isolated in an island, Taiwan contained COVID-19 spreading was initially satisfactory. Very soon, it was recognized that the transmission of COVID-19 is mainly through the respiratory route. Droplets and small airborne particles that infected people exhaled when breathing, talking, coughing, sneezing, or singing entered into the victims caused airborne infection. Therefore, personal protective equipment is prerequisite for frontline healthcare workers while caring and treating suspected and confirmed COVID-19 patients. Personal protective equipment include masks, respirators, goggles, face shield, gloves, gown, boots, etc. Such role of personal protective equipment is especially vital when aerosol-generating medical procedures are involved for medical care on COVID-19 patients. While outbreak of COVID-19 started in 2019, very soon it became pandemic. It would have been luckier for Taiwan because of its initial success in vigilance on public health measures and containment of COVID-19. But unfortunately, such luck ran out quickly, and there was a disease breakthrough in May 2021. More than 800 COVID-19 patients deceased in Taiwan during this surge period. Because of having prior SARS experiences, medical communities performed better this time. Powered air purifying respirators and video laryngoscopes were ready for supply. But in most countries, unfortunately, limited medical resources constrained the availability and accessibility of powered air purifying respirators and video laryngoscopes. Dr. Luck has served in 7 general hospitals in Taiwan during the last 40 years. Currently, he works in Hualien Tsuki Medical Center, Taiwan. He and his team introduced another safety solution for airway managers and intubators, while performing aerosol-generating medical procedures on suspected and confirmed COVID-19 patients. This solution is economically affordable, practically available, and accessible. Healthcare professionals have been looking for alternative means of protection against viral transmission. One strategy was the use of a transparent physical barriers. A Taiwanese anesthesiologist constructed a transparent 4-sided box made of plexiglass that was placed between the patient and the airway manager during tracheal intubation. After this idea was promoted by news and social media, multiple variations of barrier devices were introduced. These barriers were applied in various aspects of medical care, as well as other forms of human interaction during the pandemic. Over time, 3 general device types in barrier systems were identified: 1. Rigid transparent box, 2. Plastic sheet with frame, and 3. Plastic sheet without frame. But some people pointed out that such an unvalidated design does not reduce risks and probably has unintended safety consequences. Tracheal or endotracheal intubation is often necessary in patients with critical respiratory illness. Because it is important to place a breathing tube in the patient's airway in order to maintain patency of the airway and provide oxygenation and ventilation. The intubation process places the healthcare professional at risk for COVID-19 infection, as during traditional direct laryngoscopy. Because the medical workers need to be very close to the patient's mouth in order to obtain a view of the glottis to advance the endotracheal tube. During the COVID-19 pandemic, videolaryngoscopy is recommended to be utilized for tracheal intubation. With videolaryngoscopy, the airway manager is able to obtain a view of the patient's airway and guide the endotracheal tube through the patient's glottis without placing face in close proximity to the patient's airway. A subset of the videolaryngoscope is the video intubating stylet. This device is a rigid or semi-rigid stylet equipped with a camera at the tip projecting to a separate monitor. The endotracheal tube is mounted onto the video stylet in a similar fashion to a traditional stylet. The tip of the stylet may be designed to be malleable and anti-flex. Because the camera resides within the stylet, a laryngoscope is not necessary to perform endotracheal intubation. The intubating stylet is an economical alternative to the videolaryngoscope. Even prior to the COVID-19 pandemic, at many institutions, the video intubating stylet had become the preferred modality for performing tracheal intubation. When incorporating a barrier system with the video stylet, the length of the intubating stylet precludes its use within a rigid barrier box. The plastic sheet was the only barrier system that could be practically utilized with the video intubating stylet. The plastic sheet could be laid across the patient's head to function as a general barrier. The healthcare professional subsequently reaches under to the sheet to perform tracheal intubation. Because of its malleability and transparency, other maneuvers not involving the airway itself can be performed over the sheet. If the plastic sheet hampers the ability of the anesthesia provider to successfully intubate the patient, the sheet can be easily and rapidly removed. By using the video intubating stylet with the plastic sheet, only a single small opening would need to be made to allow the intubating stylet and mounted endotracheal tube to pass through. Prefabricated plastic sheets have been produced with seam lines to allow easy removal of the plastic sheet after successful tracheal intubation. Even without prefabricated sheets, a homemade sheet can be precut to facilitate its easy removal. Because the plastic sheet can serve as protection against contamination during the extubation process, the sheet may be left over the patient's head until surgery has concluded and the endotracheal tube has been removed. During COVID-19 pandemic, the beneficial role of videolaryngoscopy has been repeatedly advocated. However, videolaryngoscopes and video-assisted intubating stylets might not be available in some countries and regions. In that case, the airway managers should have adequate personal protective equipment while using conventional direct laryngoscope for tracheal intubation during COVID-19 pandemic. The use of a video intubating stylet in conjunction with a plastic barrier sheet may be the most efficacious method to prevent environmental contamination. But more research is still needed in this area and randomized trials should be done to prove. Nonetheless, the video intubating stylet continues to gain acceptance as an indirect video intubating device in particular regions of the world. And plastic barrier devices have shown promise to reduce environmental contamination and hospital personnel co-infection during AGMPs such as tracheal intubation. With the advantage of slim profile and minimal effect to disrupt the integrity of the plastic sheet, we can believe the video intubating stylet in conjunction with the plastic sheet will be the preferential intubating method during the COVID-19 pandemic and beyond.